Okay, welcome back to the fourth talk on renal physiology. In this one, so in the last one, we spoke about relation between potassium and hydrogen, and we saw how hyperkalemia leads to metabolic acidosis. Metabolic acidosis leads to hyperkalemia, how metabolic alkalosis comes to hypokalemia. But hypokalemia is slightly different. Hypokalemia can be associated with either acidosis or alkalosis. So when I say acidosis with hypokalemia, basically I'm talking about type 1 or type 2 RTA. So just to remind ourselves, when do we call it renal tubular acidosis? So renal tubular acidosis is characterized by normal anion gap metabolic acidosis with high chloride, and therefore it's normal anion gap metabolic acidosis with either hypo or hyperkalemia. So if you have normal anion gap metabolic acidosis with hypokalemia, you're looking at either type 1, which is distal, or type 2 RTA. And of course, if you have normal anion gap metabolic acidosis with hyperkalemia, then you're looking at type 4 RTA. We're not talking about that in this talk. Just again quickly reminding ourselves, what's the basic pathogenesis involved in type 1 versus type 2 RTA. So both of them will present with normal anion gap metabolic acidosis with hypokalemia. The problem in type 1 RTA, which is distal RTA, is the inability to excrete hydrogen. If you can't excrete hydrogen, your hydrogen stays back and you're acidotic. The problem with type 2, which is proximal RTA, is the inability to reabsorb bicarb. So normally we freely filter every bit of bicarb in the glomerular, but we reabsorb all of it, 90% in the PCT and about 10% in the distal tubule. So in proximal RTA, you're unable to reabsorb that 90% of bicarbonate in the tubule, and as you're losing bicarbonate, you're acidotic. Both of these conditions come with hypokalemia. Now, hypokalemia coming with alkalosis, I think we can differentiate into two groups. One is with normal to low blood pressure, and the other one is with high blood pressure. Of course, the biggest group is the high blood pressure and primary aldosteronism group. So the low to normal blood pressure group is either Barter or Gilman. So Barter is nothing but being born as though you are on furosemide for your life. And Gilman is nothing but being born as though you are on thiazide diuretic for the rest of your life. So remember, we spoke in one of the earlier talks, we said that when you put people on either furosemide or thiazide diuretic, so they end up becoming hypokalemic and alkalotic. And the reason is, when you're putting them on furosemide or thiazide diuretic, any diuretic acts by the principle of stopping sodium reabsorption. So the urine is full of sodium. As the urine goes to the collecting duct cells will say, oh my God, we're losing too much sodium. So they will valiantly try to reabsorb some of this or reclaim some of this sodium. But as they do that, the sodium enters the cell and the cells will say, oh my God, we're turning positive, we're going to die. So we must kick out something positive. And the chief positive ion inside the cell is potassium. So they just kick potassium out. So both thiazide and loop diuretic leads to a bit of hypokalemia. The other half of the story is when you put people on diuretics, you are volume contracting them. So renin, angiotensin, aldosterone gets activated. And as we said, aldosterone brings in sodium and water, of course, brings in sodium and a bit of water follows. But more importantly, or equally importantly, aldosterone kicks out potassium and kicks out hydrogen. So when you're on furosemide, you're hypokalemic and alkalotic, and that's the same as Barter. When you're thiazide, you're hypokalemic and alkalotic, and that's the same as Gilman. Hypokalemia with alkalosis with high blood pressure, the biggest group here is primary aldosteronism, when you're just making too much of aldosterone. You're making up too much of aldosterone, reabsorbing sodium and water follows, and therefore you're hypertensive, losing potassium, losing hydrogen, so you're often alkalotic and a bit hypokalemic as well. Liddle syndrome. So remember, when we spoke about aldosterone, we said that aldosterone, it activates the sodium potassium ATPase channel in the collecting duct cells to work extra hard. So the cells are more hungry for sodium. And B, it keeps the epithelial channel through which sodium enters from the urinary lumen into the cell. It keeps that channel wide open. That's called ENaC, epithelial sodium channel. Liddle syndrome is a condition where that channel is just wide open madly. It just keeps reabsorbing sodium. So as you keep reabsorbing sodium in response to compensate, cells lose potassium and hydrogen. So you're hypertensive, alkalotic, and hypokalemic. Of course, your endogenous aldosterone level is going to be low because you're just reabsorbing sodium like mad. Finally, apparent mineralocorticoid excess. So cortisol can do pretty much the same fancy stuff that aldosterone does on the kidney tubules. And remember, the concentration of cortisol is, I think, a few hundred times more than aldosterone. But thankfully, the kidney has made something called 11-beta hydroxysteroid dehydrogenase type 2. You probably don't have to remember the name of the enzyme, but what you need to understand is in the kidneys, this particular enzyme deactivates cortisol into cortisone, which is metabolic and inactive, and cortisone is lost in the urine. Now, if you have a problem with that enzyme and if that enzyme is mutated, it can't do what it's supposed to do, So cortisol hangs around in the kidney, and cortisol does exactly what aldosterone is supposed to do, which means it will reabsorb sodium and water and kick out potassium and hydrogen. So you're hypertensive, alkalotic, hypokalemia. Of course, your endogenous aldosterone levels will be low. Just remember that licorice inhibits the same enzyme. So literature says that if you take 150 gram of licorice for 2 weeks in a row, you can push your blood pressure up, because then your cortisol hangs around in the kidney and it starts doing the fancy stuff that aldosterone does. So with this, we come to the end of this talk. I will later on try to record a short video on the 3 types of renal tubular acidosis. Thank you guys. I hope you have had a good time listening to me.